This presentation is on concepts related to urinary elimination. Please review the anatomy and physiology of the urinary system very briefly to identify the role of the kidneys, the ureters, the bladder, and the urethra. A brief review of the anatomy of the female urinary tract demonstrates that the urethra is very short. When putting a catheter into the female urinary tract, only a small length of the catheter must be inserted in order to access the bladder. This figure depicts the male urinary tract. In the case of the male, the urethra is much longer than in the female. The urethra is also surrounded by the prostate. Therefore, a much greater length of the catheter must be inserted via the urethra to reach the bladder. The prostate may inhibit passage of the catheter due to enlargement. There are many factors that affect urination. Age is one. Newborns, for example, don't concentrate urine well, therefore they void quite frequently. In addition, toilet training doesn't take place until around 18 to 36 months. There are also changes in urination as we age. Over time, women lose abdominal and perineal muscle tone due to childbearing. This can lead to some leakage of urine. Males may have prostate enlargement. Some personal, socio-cultural, and environmental issues play a role in urination as well. Delays in voiding may occur because the people are busy working, like nurses, for example, or doing other activities that can promote urinary stasis, and may lead to bladder infections. Anxiety and stress can play a role in urination. If a person is under stress, that tension can make it difficult to relax the abdominal and perineal muscles, making it difficult to urinate. Lack of time and privacy can be an issue. Most people in the United States particularly require privacy in order to use the restroom. They get embarrassed about asking for restrooms or asking for assistance to the toilet. Think of the elder clients that we work with who need assistance to the toilet. Many may be uncomfortable asking for your assistance due to the perceived loss of dignity regarding their immobility or the need for assistance. Think about bedpans and urinals. We as nurses need to acknowledge these feelings, not minimize them. To us, using a bedpan or a urinal is no big deal, but to the client, sometimes it can be really upsetting. Cultural influences can also play a role in urinary practices. Many persons may prefer to have the assistance of somebody who is their same gender. They prefer to have their modesty respected during their toileting practices. Having a healthcare provider standing right outside the restroom door could be upsetting to somebody of different cultures. Nutrition, hydration, and activity level can play a role in urination as well. Normal daily fluid intake is roughly 1,500 to 3,000 ml, so you need to remind clients to drink fluids. Keep fluids within easy reach of clients because inadequate intake leads to dehydration and then less urine output. Clients may avoid or consume excess caffeine. Caffeine is a diuretic and increases output. Alcohol in large volumes impairs release of antidiuretic hormone, resulting in increased production of urine. High salt diets can cause water retention and decrease urine production. These are only a few examples of diet causing changes in urinary patterns. Surgery and anesthesia can decrease urine output. If the urinary tract and the surrounding tissue are manipulated as part of the surgery, for example, trauma, bleeding, or edema may occur, which can cause obstruction. If there is an introduction of bacteria into the urinary tract, this can lead to urinary tract infection. Anesthesia, in general, decreases the client's awareness of the need to avoid promoting stasis of urine in the bladder, which may cause overextension of the bladder and a loss of ability to void. A urinary catheter could be indicated to deflate the bladder and allow the muscles to return to normal, thereby promoting a return to normal voiding. There are also a variety of diseases and disorders that can affect urination. Local or systemic infection, inflammation, stones in the bladder, tumors, excessive growth of glands like the prostate gland, and immobility can all result in urination being affected. Medications like diuretics will increase urine output. Other medications like anticholinergics cause retention of urine and decrease output. Some meds like pyridium can even change the color of the urine. Pyridium turns urine very red. Because there are so many things that affect urination, as with all the other system assessments that we've been doing, there are some system-specific focused history questions that we ask when performing our assessment. The nurse doesn't necessarily ask every question, but determines which are pertinent as part of this particular client's assessment. Many of these focused history questions will be asked as part of the head-to-toe assessment that you will be doing for comps. For example, have you noticed any redness, swelling, discharge, or odor in your genital area? How often do you urinate? How much volume? Is there any unusual odor? Then ask appropriate history questions like whether or not they've ever had any problems urinating, any retention, leakage, infection or bladder problems, etc. Just as has been done for assessing the other body systems, start with inspection. Inspect the abdomen and skin. Remember, the skin assessment findings on the abdomen will be documented under integumentary. Look at the abdomen to note if there are any areas of distension, any abnormal pulsations, striae or stretch marks, skin texture and color, and any abnormal skin changes. Next, palpate the abdomen. Remember to palpate gently in a circular motion in all 4 quadrants, looking for masses or areas of sensitivity. While palpating the abdomen, if you identify a hardened, rounded area at the base of the abdomen, that's often the bladder. Next, you will inspect and palpate the external genitalia and the urinary meatus. Look for things like hair distribution, which increases at puberty. Look at the skin condition, texture, presence of stool or urine or redness. These observations can give the nurse evidence of the client's hygiene practices. Look closely at areas where skin breakdown can occur. Is there discharge, swelling, or presence of odor? Diagnostics and labs are also done as part of the urinary assessment. Urine is often sent to the lab for a urinalysis or other lab studies. Blood studies are also done, including BUN, or blood urea nitrogen, and creatinine levels, which are used to assess renal function and hydration status. A bladder scan may be done to determine the volume of urine in the bladder. An excessive amount of urine remaining in the bladder may be an indication to place a urinary catheter. A cystoscopy is a direct visualization of the urethra and bladder done by inserting a scope. An ultrasound or CT scan may also be done of the urinary tract and bladder. As part of these different diagnostics and labs, it's likely that specific nursing care and client education will need to be done. For example, the client needs to be made NPO prior to doing certain procedures like a cystoscopy. Client teaching about the importance of emptying the bladder before other procedures may also need to be done. Characteristics of normal urine. Normal urine is pale or straw-colored, or even colorless. If urine is dilute, it will be colorless. If urine is concentrated, it will be much darker, particularly if a client hasn't urinated for a period of time, like overnight. Normally, there is little to no odor. If there is a foul odor, or it is really strong smelling, like ammonia for example, there may be some bacterial presence. That would be abnormal. Sometimes certain foods may increase odor like garlic and onions and asparagus. Normal urine is clear, not cloudy. Specific gravity is a measure of the amount of dissolved solutes in a solution. As the concentration of solutes increases in urine, so does the specific gravity. If a person is dehydrated, the urine will be darker and the specific gravity increases. In other words, there's less fluid per amount of solutes or dissolved components. We'll talk more about this later in the week when we talk about fluid management. Normal pH is between 5 and 9, with an average of roughly about 6. If it's increased, that can be related to a vegetarian diet or high intake of dairy products. If it's decreased, it's more acidic and may be from high protein diet, or maybe they've consumed cranberry juice. Normal output is 0.5 to 1 ml per kilogram per hour, or 50 to 60 ml per hour, or 1500 ml per day. But output depends on a lot of different factors, so urinary output fluctuates depending upon how much fluid has been consumed, the ability of the body to void, and the ability of the body to concentrate fluids. Whether or not a client's urine output is within defined limits is easily calculated. For example, a 150-pound client has a urine output of 1,100 ml over the past 24 hours. I'll let you do a little bit of math to determine if this client's fluid output is what you would anticipate based on defined limits. You can pause here, do the math, and then resume. The takeaway from this slide is that while there are general guidelines, normal output is generally defined as 30 ml per hour. If output is less than 30 ml per hour, we need to assess for what's going on with the client and typically report that finding to the healthcare provider. Oliguria is defined as 100 to 400 ml per 24 hours. That is a significant decrease in urine output that can indicate impending renal failure. So rather than waiting and looking at a whole 24-hour period to see how much a client has in terms of output, it's a much better idea to assess as you go, looking for an output of 30 ml per hour. Remember though, you don't urinate exactly 30 ml per hour. You may go every couple of hours. If a client has no output for an entire shift, the nurse needs to make sure to assess the client for distension and report it to the provider. So how do nurses promote normal urination? Providing privacy is probably the most important thing you can do. Close the door or the curtain. Provide some time for the client. Try not to hover in the doorway and keep asking, "Are you done yet? Are you done yet?" If somebody is hovering, you know it makes it really difficult to urinate. Another thing to consider is positioning. Males typically stand up to void, so whenever possible, assist them to the bathroom to void or help them to stand at the bedside and use a urinal or bedside commode. Let's get them standing whenever possible as long as it's safe. Females prefer an upright, seated, or squatting position. When providing the bedpan, the client is placed in a semi-Fowler's or upright position for the client, who is female. But this is still not a normal position for voiding, so a bedpan is not ideal. If the female client can't make it to the bathroom, a bedside commode is a much better alternative. If possible, facilitate the client's normal voiding routines or normal toileting routines. Identify the pattern that the client uses and stick with it. Assist them to the bathroom or bedside commode at regular intervals, especially if they have mobility issues. Don't forget to instruct your UAP or CNA to not make the client wait. Let's get them on a schedule. For client comfort, we want to make sure that we promote adequate fluids and nutrition. 8 to 10 8-ounce glasses of water daily is sort of the age-old rule of thumb. Keep fluids in easy reach. Provide them some goals for consumption. If the client is not good at drinking adequate fluids, give them a graduated cup and tell them how much they need to consume every hour or every couple of hours. Offer clients a straw because they tend to drink more this way than when sipping it from a cup. Chilled drinks also go down easier, especially if the client has a really dry mouth. Providing frequent mouth care will assist your client as well. Now, all these interventions, like keeping fluids in easy reach and 8 to 10 glasses per day, are obviously for the client who does not have a significant issue with fluid retention. A client who does not have kidney failure, for example, can have adequate fluids within reach, but a client who has kidney failure may have a significant limitation on the amount of fluid that they're allowed to have. Same thing for a client with heart failure. Those clients tend to have a limited volume of fluid that they are allowed to consume. Assist with hygiene. Urine is really irritating to the skin. So if your client has used the restroom, make sure that you assist them as needed to clean urine off of their skin. There are several different methods to obtain a urine specimen. You will practice some of these in lab. The midstream catch or the midstream clean catch is a non-sterile means of obtaining a urine specimen. Typically, the nurse or the client cleanses the perineum or the glands of the penis with the antiseptic towelette. For females, always make sure to clean from front to back on the left labia, then front to back on the right labia, and then down the center over the meatus last. For males, cleanse in a circular motion, starting at the meatus and making the way down the shaft. Maintain sterility of the container itself to the best of your or the client's ability. Don't touch the inside of the sterile container. When the container is uncapped, place the lid on the table such that the inside of the lid is facing up. Have the client start the urine stream and then move the container into the stream. Collect about 30 to 60 mLs of urine and then remove the container from the stream and allow the client to finish voiding. Once the sample is obtained, put the lid back on tightly and write the time, the date, your initials, and the client identifiers on the label. Then, double bag and send it to the lab. The 24-hour urine collection is the gold standard for measuring glomerular filtration rate. The urine is collected over 24 hours because different amounts of substances are produced and concentrated in urine throughout the day. So a better indication of what's going on in the body over time is determined. A large collection container that is typically supplied by the lab is used to collect all of the urine voided in a 24-hour period. Sometimes more than one container is required if a client is putting out large volumes of urine. To begin the collection, the client is asked to void. That first void is discarded, and the time of that void is then recorded as the beginning of the urine collection period. All urine that is produced over the next 24 hours is kept in the collection container. Make sure to inform all staff that a 24-hour urine is in progress. Often signs are posted in the room to remind staff not to discard urine. Remind the client and their family too, because if at any point any of the urine gets discarded during the 24-hour time period, the test must be started over. Some facilities require that the urine is kept refrigerated or kept on ice. So you may walk into a client room and see a bag of urine, like a Foley catheter bag of urine, sitting in a bath basin with ice water. As soon as the 24-hour urine collection is completed, send it to the lab to get the most accurate results. In lab, you will practice obtaining a sterile urine specimen from an indwelling Foley catheter. In this case, the catheter has a balloon inflated that holds the catheter in place. Urine will be collected from a port on the catheter tubing. In this picture, identify the syringe attached to the port on the catheter tubing. Urine is not taken from the catheter bag because that urine has been in there for a period of time and it is not considered appropriate for a sterile urine collection. To obtain the specimen, clamp the drainage tube distal or below the port for 15 to 30 minutes to allow production of urine for a fresh, sterile sample. Literally, just bend the tubing and put a rubber band on it, or sometimes a special clamp is available. When it is time to obtain the specimen, scrub the hub for 15 to 30 seconds to make sure that the hub, the place where we're attaching the syringe, is clean. Then maintain sterility by attaching an empty 10 ml syringe aseptically without touching it to anything else. Then pull back on the plunger to remove a specimen. Remove the syringe, put the specimen into a specimen cup while maintaining the sterility of the inside of that cup by not touching the inside of it with the syringe or your fingers. Remember to unclamp the tubing or urine will back up into the bladder, potentially causing an infection. It's really important to note when doing this type of sterile collection from a urinary catheter that we do not disconnect the tubing and that the tubing is never punctured by the needle. These are some examples of non-sterile collection containers. On the left side is a commode. Urine can be collected in the bowl that's attached to the bottom of the commode. The urine can then be measured. In the middle is what's called a hat that sits in the commode or in the toilet underneath the seat. It has graduations that show the level of urine for measurement. To place it in the toilet or commode, lift the seat, set the hat on the rim of the bowl, making sure that the circular hole or bowl is towards the front of the seat. Then close the seat over the top of it. Make sure that when a client is using a hat to collect their urine, that they know not to throw the toilet paper into the hat because that alters the amount of fluid in the hat when you are trying to measure it. Below the hat is a urinal with graduated markings. To the right of the urinal is a graduated container used to collect urine from a Foley catheter bag for measurement. In the upper right corner is a 24-hour urine collection container. It looks small in this picture, but in reality it's actually quite a large container. Take a moment to try and answer this question. You can pause the video if you like. The correct answer is D. The most accurate results are obtained when the specimen is fresh and sent to the lab immediately. Here's another question. Pause the video and answer it. The answer for this one is C. Palpating the bladder of a client with urinary retention is not the role of the unlicensed assistive personnel or UAP. That's an assessment, so that's the nurse's job. Administering a continuous bladder irrigation is an intervention that will be done by the nursing staff. Providing indwelling urinary catheter care makes sense because they can, as your aide, clean the catheter to make sure that we aren't increasing the risk for infection. Obtaining the client's history, an assessment again, that's a nursing role, not a UAP or CNA role. Before we go any farther, please make sure that you know these terms. There is a doc available in D2L to help you with memorization. I'm going to quiz you on these when we get back to class. Incontinence is the loss or lack of voluntary control over urination. You've likely experienced this with your clients in long-term care. It's common, but it is not considered a normal change of aging. For each of the following types of incontinence, use your resources to determine definitions for each of them and the causes, as well as some nursing interventions. Let's talk about some of the nursing management for the incontinent client. Skin care is obviously one of the most important things. Be very diligent about keeping the perineal area clean and dry to avoid skin breakdown. Use drip collection pads or briefs. Make sure that these are checked and changed very regularly. Pelvic floor muscle rehabilitation exercises, commonly known as Kegel exercises, can help strengthen pelvic muscles. They must be done daily and for several months consistently to be effective. Ask the client to hold the pelvic floor muscles tight or tense as they would normally do to stop the flow of urine. Hold these muscles tense for 5 to 10 seconds. Repeat 10 to 15 times per set. Do 3 sets per day. Bladder training or scheduled voiding involves teaching the client to postpone urination until a scheduled time. Assist the client into the restroom or put them on the bedside commode at each scheduled time. This can help with urge incontinence. Some clients have also been successful using biofeedback for incontinence. Some people will do intermittent self-catheterization. They will periodically self-catheterize in order to drain urine so that it doesn't build up within the bladder. As far as body image and embarrassment go, just be professional. Let them know that incontinence is something that you deal with regularly and that you have some tips and tricks to share. Teaching about when to call the health provider is also important. Explain to the client to call the healthcare provider for signs and symptoms of urinary tract infection, like burning at the urinary meatus, fever, chills, pain, or if they pass very little urine for 1 or 2 days, or if there's discharge present. The urine is cloudy or foul smelling are also reasons to contact the provider. Urinary retention is the inability to empty the bladder, or after emptying a small amount from the bladder, there is still a considerable amount of urine left in the bladder post-voiding. Acute urinary retention is the sudden and often very painful inability to void despite having a full bladder. It's a medical emergency and it requires prompt attention. Chronic urinary retention is painless retention often associated with an increased volume of residual urine. Urine is left in the bladder after voiding in situations like benign prostatic hypertrophy. Symptoms can be frequency, having to go to the bathroom often, a weak or interrupted stream of urine, trouble initiating a stream of urine. These clients typically tend to report a mild sort of constant discomfort in the lower abdomen. This can also become an acute situation for a client who has BPH. Some of the complications that can occur with urinary retention are urinary tract infection, bladder damage because the kidneys continue to produce urine even if it isn't leaving the body, and injury to the kidney due to backup of urine into the kidneys. There are many different causes of urinary retention. Urinary retention in men is most commonly due to an enlarged prostate creating an obstruction. Other forms of obstruction are stones, tumors, blood clots, scar tissue, or even impacted stool. If stool is building up in the GI tract, it can actually put pressure on the urinary tract and cause an obstruction. Other sources of obstruction include inflammation and swelling or edema from infection or from surgery. Anxiety related to pain with urination can cause fear of urinating, so the client just doesn't urinate. Medication or anesthesia may tighten the urinary channel, causing a block in the flow of urine. Remember that voiding requires that the brain, the spinal cord, and the nerves all be intact. Therefore, an injury to the spinal cord or infections that affect nerves can cause retention. The main things to take away from this slide are that if a client complains of issues related to urination, such as an inability to empty the bladder or only a small amount of output, palpate the abdomen first to check for distension. If you find distension, notify the healthcare provider because this could indicate retention or infection and possibly the need for a catheter. Nursing management of urinary retention includes palpation for distension and notifying the healthcare provider of assessment findings. One assessment that would be pertinent to report is a post-void residual measurement, or PVR. This means that after voiding, there is still residual volume left in the bladder. A bladder scan is done after the client voids to identify how much urine is still in the bladder. That is what you will see in the picture on the right. An ultrasound probe is used to scan the bladder. At the bottom, you see the readout where it tells how much urine is in the bladder. An alternative, invasive way of checking PVR is to have the client void and then perform a straight catheterization, also known as an in and out catheterization. In this case, a catheter is inserted and the remaining urine is drained and measured. Based on the PVR, a healthcare provider might order placement of an indwelling urinary catheter, also known as a Foley catheter. Sometimes the healthcare provider will order intermittent urinary catheterization. In this case, the nurse periodically straight catheterizes the client, or the client is taught to perform intermittent catheterization. The Credé maneuver is a technique used to void urine from the bladder when a client has a urinary tract disease or is unable to void on their own. Manual pressure is exerted on the abdomen at the location of the bladder just below the umbilicus. This pressure causes the client to be able to void. Clients can learn how to do it themselves. Medications for loss of bladder tone, for example, cholinergic medications like bethanechol, stimulate contraction of the detrusor muscle to trigger bladder emptying. If the client has poor bladder emptying, alpha adrenergic antagonists like doxazosin will reduce urethral resistance. So a variety of medications can be used. What is urinary catheterization? Urinary catheterization involves feeding a tube into the bladder to allow the drainage of urine. When is urinary catheterization done? It can be done to obtain a sterile urine specimen, to measure post-void residual, to monitor output in the critically ill or immobile client who needs very tight management of their output, to prevent contamination during surgery and after, to protect excoriated skin from contact with urine, and to reduce the need for unnecessary movement of a client near death. It's really a last resort. We don't just put a catheter in everybody because it makes our lives easier. It isn't done for the client who's incontinent, so we don't have to change the brief or pad as frequently. Some clients receiving Lasix, a diuretic, will ask for a catheter because they don't want to have to get up to go to the bathroom multiple times. We don't do it to make their life easier either. We put in a urinary catheter only when necessary. There are a number of different types of catheters with different uses. A straight catheter, also known as an intermittent catheter or an in and out catheter, is pictured in the upper right with a blue background. You see a shallow tray that has cotton balls and forceps and lube. These are some of the materials used when inserting the catheter. Then you see coiled on top of the other materials in the deeper tray is the catheter. You'll notice that the catheter is not attached to a long tubing or to a bag of any kind. That's because it's an in and out catheter. It is put in and then removed from the bladder immediately after draining the urine. The urine drains into that deeper plastic tray. Another type of catheter is what we call an indwelling urinary catheter, also known as a Foley catheter. But indwelling urinary catheter is the best term for it. An indwelling catheter allows for continuous flow of urine out of the bladder. Look at the picture in the middle. You'll see a picture of the bladder. The catheter goes into the bladder, and inside the bladder, near the end of the catheter, is a balloon that has been inflated. When that balloon is inflated, the catheter can no longer slip out of the bladder and urethra because the balloon is holding it in place. On the right, where it says Foley catheter, you can see how big that balloon is in comparison to the size of the catheter. The catheter is then hooked up to tubing, which then hooks up to a bag. It may be a leg bag, like in this picture, or the big Foley catheter bag that you're used to seeing attached to the bed. The lower picture is a suprapubic catheter. Supra, above the pubic area, in other words. In this case, an opening is made in the wall of the abdomen through which a catheter is placed and a balloon inflated to hold it in place in the bladder. Notice that the catheter there on the lower left is not going through the urethra of that male client. It is going through the abdominal wall. This type of catheter is used for urine drainage when the urethra needs to be bypassed due to some sort of trauma or obstruction. Because it is inserted surgically through that abdominal wall and into the bladder, it's really important for the nurse to assess the skin around the insertion site for breakdown and to perform teaching with the client regarding skin care. If infection is suspected at the insertion site due to the presence of redness, inflammation, pain, or purulent drainage on the dressing, contact the healthcare provider immediately. This is a Coude catheter. It is used for a client with significant urethral stricture due to BPH or prior prostate surgery in males, prior radiation in the pelvic area to treat cancer, females with atrophic vaginas, and prior urethral injury. The tip of the catheter has an upward curve, and it is made of a stiffer material, which makes it easier to pass the catheter through the urethra that has been narrowed by the hypertrophy of the prostate, which surrounds the urethra, or any other disease process that has caused urethral stricture. Here are a number of different types of catheters. The upper one, A, is an in and out catheter. Remember, this type is used to drain the urine in a client with acute bladder distension, for example, for a client who's had anesthesia and is having difficulty resuming urination. B is an indwelling or Foley catheter. You can see that there are two ports or two lumens. A lumen is just a tube. So in the case of B, it's like having two tubes put together. Note that there's a balloon inflation tube, and then note that the urine drainage tube is next to it. The fluid that is put into the balloon port never mixes with the urine because they are two separate lumens or tubes. The bifurcation is where the balloon tube comes off to the side, making a Y. Fluid inserted here inflates the balloon. The other tube is the tube that allows urine to flow out. Note the little eyelets or openings on the distal end of the tube. This is where urine in the bladder enters the tube. It travels down the catheter and out through the urine drainage tube attached to a bag. C is a three-way catheter. The catheter tip looks the same. The balloon port looks the same. However, in this case, there is another tube which is used to irrigate the bladder. So in this case, one tube or lumen is the port for the balloon inflation, one lumen for urine to move out through, and a third lumen that allows fluid to flow into the bladder, and then that fluid can come back out through the urine output lumen, along with the urine that's produced by the body. When doing intake and output recordings where fluid intake and output are documented, intake is the amount of fluid that is instilled or put into the bladder via the third lumen. Output is the amount of urine plus the fluid. Output is the amount of urine and fluid that comes out via the urine output lumen. Urinary catheters come in different sizes. French is the sizing or the unit that is used for catheters. An 8 or 10 French catheter has a much narrower diameter. The diameter of the lumen is smaller, so you can imagine we use those for children versus a 14 French or a 16 French, which is most commonly used for adults because it is a larger diameter catheter and adults have a larger diameter urethra. Up to an 18 French catheter can be used for male clients. Catheters also come in different lengths. A 22 centimeter catheter is typically used for a woman because a woman's urethra is shorter. Because the catheter has to go all the way through the much longer urethra in a male to get to the bladder, the catheter length is usually 40 centimeters for the male client. This slide provides further visualization of the length of the catheter in the male and female. Please note, often the hospital only has one length of catheter and it will be long enough for the use in the male client as well as the female client. Just a quick note, when the indwelling urinary or Foley catheter comes out of the packaging, it is attached to a bedside collection bag like the one on the left. This is hung on a non-movable part of the bed or gurney. If the client is mobile, the healthcare provider may order use of a leg bag. In this case, the tubing is aseptically removed from the bedside collection bag and then aseptically connected to the leg bag. The leg bag is then strapped to the client's thigh. This allows the client to ambulate more freely. It is no longer considered evidence-based practice to inflate the balloon to check for function or to check to see if the balloon has a hole in it prior to placing the Foley catheter in the client. The fear was that after doing a lengthy involved sterile procedure to get the catheter into the client, that the nurse would inflate the balloon and it wouldn't inflate, so the procedure would need to be done again. Research has shown that the balloon is virtually always intact. In addition, blowing up the balloon and then deflating it causes ridges to form on the balloon, which can cause irritation as the catheter is inserted or removed. If you've ever blown up a balloon and let the air go out of it, you have seen that the balloon after deflation is larger in size and is lumpy. It no longer looks like that smooth, small balloon you started with. So you can imagine if you pre-inflate the balloon, instead of passing a sleek, smooth catheter into the bladder and then inflating the balloon, you are inserting a wrinkly catheter, which is irritating to the urethra. Nursing care for the indwelling urinary catheter has 3 major principles. Keep it closed, keep it flowing, and keep it clean. Let's go through each of these. To prevent urinary tract infection, it is necessary to maintain a closed system. The system that is closed has less chance for pathogens to enter. Therefore, unless specifically ordered, never disconnect the tubing. If the tubing is disconnected, a path or runway for pathogens is opened. To maintain the closed system, regularly check all connections to make sure that they are secure. Check the connection of the catheter to the tubing and the tubing to the bag. It may be necessary to disconnect the catheter from the large Foley catheter bag and attach it to the leg bag so that the client can be more mobile. Again, if making this change, do so using strict aseptic technique and be sure that the tubing is secured to the bag. If for some reason an unanticipated disconnection occurs, make sure that you wipe both ends with alcohol or chlorhexidine before you reconnect them. Also along the lines of preventing infection, the next principle is to keep it clean. After each bowel movement, the catheter needs to be cleansed with mild soap and water. Clean from the meatus towards the bag, not the other direction. If you clean from the bag end towards the meatus, bacterial contaminants are brought towards the urethra. Cleansing of the catheter is also done at least once a shift or per facility policy and procedure. Another way to reduce risk of infection when working with an indwelling catheter is remembering to use standard precautions. Wash your hands well before applying gloves to manipulate the catheter and performing catheter care. To keep it flowing, empty the collection bag at least every 8 hours to prevent stagnant urine sitting in the bag. Stagnant urine is a good place for bacteria to grow. Keep the collection bag below the level of the bladder. This allows gravity to pull the urine into the bag, promoting normal urine flow. In addition, if the bag is raised above the level of the bladder, backflow of urine into the bladder may occur. Therefore, any stagnant urine that's been sitting in the bag has now gone back into the client's bladder, increasing the risk for infection. Keep it below the level of the bladder, but please don't let it touch the floor. The floor is considered contaminated and the Foley bag does not belong there. When emptying the urine from the bag, make sure that the spout through which the urine is emptied doesn't touch any surfaces, even the inside of the container that the urine is drained into. After draining all of the urine from the bag, wipe the spout with an alcohol swab and then place it back into the securement place on the bag. Another way to make sure that urine is flowing freely through the catheter is to frequently inspect the catheter and tubing for kinks. Also make sure that the client is not sitting or lying on the catheter, preventing flow. Finally, promote normal urine production by encouraging oral intake of at least 8 to 10 8-ounce glasses of fluid per day. Monitor the client's intake and their output at least every 8 hours. Encouraging the client to be active and out of bed as much as possible will also promote normal urine production. Maintaining skin and mucosal integrity is also paramount. Securing the tubing to the client's thigh is important to prevent movement of the catheter within the urinary meatus, bladder neck, and bladder. Movement of the catheter causes irritation and potentially broken mucosa, leading to increased risk for infection. Make sure that there is no traction or pulling on the catheter when it is secured, because a pressure injury can form. As above, make sure to assist with hygiene as needed daily and post each bowel movement. When doing so, monitor the urethral meatus and the upper drainage tube for incrustation. This is a buildup of sandy particles on the catheter near the meatus, which can irritate the mucosa. If buildup occurs, the catheter will need to be changed. Catheter-associated urinary tract infections, or CAUTIs, are a big deal, so this is a major focus of all of our hospitals and long-term care facilities. In order to prevent CAUTIs, catheters are only placed when absolutely necessary and are removed as soon as possible when the catheter is no longer indicated. Client education must be provided before insertion, and client consent must be obtained prior to insertion. A competent person must insert the catheter, and they must use aseptic technique or sterile technique when inserting the catheter. Monitoring of the catheter to ensure that there is unobstructed flow of urine is also imperative. Urine specimens are only collected when clinically indicated. An evidence-based CAUTI prevention tool is available in D2L for your review. Try this select all that applies question. Hit pause, choose your answers, and then check your answer. The answers are B, C, and D. The only one that requires an RN skill is flushing the catheter, which requires assessment skills and more specialized care of the client. Urinary diversions, or urostomies, are the final topic for this video. A urinary diversion is created when for some reason there is a blockage at some point in the urinary tract, or there has been removal of anatomy, like the bladder, due to cancer or other tumor. Normal flow of the urine is from the kidneys, down the ureters, into the bladder, and out through the urethra. If this pathway is compromised, a surgical pathway or diversion creates an opening for the urine to be eliminated via a different route. There are different types of diversions. One of the common ones is the incontinent urostomy. Ileal conduit or ileal loop are names for it. This type of diversion is a continuously draining urostomy. In other words, it is not continent. The client doesn't have control over when urine is expelled from the body. We will review some images of this type of urostomy shortly. The second type of urostomy is a continent urostomy, where the urine is stored in a surgically created pouch called either an ileal reservoir or an Indiana pouch or a Koch pouch. This is an image of an ileal conduit. The surgeon removes a small, roughly 1 to 2 inch long piece of the small bowel. The surgeon cuts the section out of the small bowel and then sutures the two ends of the bowel together. This is called anastomosis. It is as if the piece was never removed and the bowel is again continuous. The small piece of bowel that was removed is sutured closed at one end. The ureters are then implanted into the small piece of bowel. A puncture is made in the abdominal wall, and the open end of the small piece of bowel is pulled through the opening, turned inside out like a turtleneck sweater, and then the turned down edges are sutured to the exterior abdomen. At this point, a stoma has been created. What is visible is a small lump of pink tissue that was formerly the mucosa on the inside of the small bowel. Urine is now able to be formed in the kidneys, travel via the ureters into the ileal segment, and out through the stoma. In other words, it has been diverted from its normal path through the bladder and urethra. A urostomy bag or urostomy appliance is applied over the stoma to catch the urine. This type of diversion is incontinent. As urine is produced, it continuously drains into the bag. This bag is emptied regularly via a port at the bottom of the bag. The bag is usually only changed every 7 days or so. Because the small bowel produces a lot of mucus to help move stool through the bowel, the urine that drains into the urostomy bag may have a bit of mucus in it. So don't be alarmed if you see this when caring for a client with an ileostomy. Make sure to provide really good skin care to the peristomal skin because urine has a different pH than skin, which can cause skin breakdown if it remains in contact with the skin for any length of time. Another potential complication is backup of urine into the ureters or kidneys due to an overfilled bag or kink in the ureters. This could result in significant kidney injury, so monitor urine output regularly. This is an Indiana pouch, a type of continent urinary diversion. In this case, a bigger piece of the bowel is resected and a pseudobladder is made by creating a pouch by pushing the small bowel back into itself. It causes part of the bowel to encircle the portion of the small bowel that is then pulled through the abdominal wall to make the stoma. Because of this encircling of the exit tube, fluid pressure closes this makeshift valve and the urostomy is continent or not leaking urine continuously. The only way to get the urine out is to catheterize the stoma. Clients are taught to perform intermittent catheterization themselves. In the right image, you see a client with a urostomy performing self-catheterization. She has inserted a catheter into the stoma and she's drained the urine into the toilet, which she's sitting on the edge of. This client doesn't have to wear an ostomy pouch or bag or appliance, all the same thing. But she will self-catheterize every 4 to 6 hours or so. As we mentioned earlier, skin care is paramount. It is also important to monitor the stoma. It should be pink and moist because it is still a living piece of bowel with all the blood vessels it would normally have. It should be moist because it is mucosa and produces mucus. Urine should be clear or straw colored and may have a little bit of mucus in it, but there shouldn't be anything unusual about the color of it. Self-image is another concern for these clients who have a stoma, whether they have to use an ostomy bag or not. Be supportive and provide good teaching on stoma care, changing the bag, self-catheterization if appropriate, infection prevention, etc. More about stoma care and emptying and changing the bag will be taught in a future skills lab. Here's another select all that apply for fun. Pause the video, choose your answer or answers, and then check to see if you are correct. The correct answers are B and D. The coach pouch is a continent urostomy with a surgically created pouch that allows it to have a type of valve. We will practice using the catheter together because we need to teach the client how to self-catheterize every 4 to 6 hours. There's a stoma with this type of urinary diversion, so A is incorrect. And there is no need to wear a drainage bag because we have a continent pouch, so C is not correct either. Here's a question about a client with an ileal conduit and preventing urinary tract infection. Pause, choose, and then check your answer. The correct answer is B. Maintaining a high fluid intake is most effective in preventing UTI because it prevents urinary stasis and bacterial growth. In other words, keep moving fluid through. Avoiding people with respiratory tract infections isn't going to help because the question is about a urinary tract infection. Using sterile technique to change the appliance or bag is not necessary. The bag is changed using clean technique, again because it's filling up with urine all the time. Irrigating the stoma with antiseptic is not necessary. Remember that bag is going to be in place for 7 days, so we aren't going to be irrigating the stoma. And using an antiseptic would be very harsh on the exposed bowel lining. The remaining portion of the slideshow we will be going over in class. I look forward to seeing you then.